Okay, hello, students. I hope I'm audible and everything is clear. Yes, I hope I'm audible. Can we send a reply? Audio and video, everything. Okay, hello, students. I hope I'm audible. Yes, good. Thank you so much. So we'll start the session for today. So this session is about G protein coupled receptors, an important topic not only for pharmacology, even actually it is more of physiology areas. So why is it G protein coupled receptors very important? It's because this is point number one, very important question for your exams. So a question might be asked based on the clinical scenario. A question is going to be thrown up to you asking about GPCRs. And the second one is how this G protein coupled receptor is involved in certain drugs and its mechanisms of action. We'll be having a basic explanation. This session, as I've told already, will not be lasting more than 30 minutes of time. Don't worry. I will try to concise the materials as much as possible so that it's going to be easily palatable for you. Let's start with the first concept. What exactly is this G protein coupled receptor and why do we have a need to have a receptor? Consider this is a cell. Inside the cell, we have a nucleus. Inside the cell, we have a nucleus. Any impulses from the outside, be it a drug, this impulse must reach the nucleus to either increase the synthesis of proteins or decrease the synthesis of proteins. Only two major possibilities are there. So how this drug is going to be reaching that? For example, if this drug is going to be lipid soluble in nature, it can easily cross the barrier and do all the responses. But this drug is not a lipid soluble drug. This drug is going to be a water soluble agent. If it is a water soluble, it is not going to be penetrating any of the membranes. So what happens? There will be a receptor which will be there on the surface or on the membrane itself. This receptor is called as transmembrane receptors. Now, via this transmembrane receptors, the drug is going to be interacting with this. This extracellular domain will be interacting with the drug. From the intracellular domain, there will be release of certain substances, and these substances in turn will gain entry inside the nucleus to either stimulate or inhibit protein synthesis. Now comes the next important question, buddy. How this protein synthesis is going to be increased or decreased? It is purely based on the molecule which is released from the intracellular domain. Clear? With this concept in mind, we'll be explaining further. This transmembrane receptor, this receptor which we have written called as transmembrane receptor, we have many different subtypes. One important subtype is G protein coupled receptor. One important subtype is G protein coupled receptor. Now let's look into further buddies. As per GPCR is concerned, we have three different subtypes of G protein coupled receptors. GPCR type A, GPCR type B, and GPCR type C. G protein coupled receptor type A, example, we have muscarinic. Muscarinic, which is a receptor for acetylcholine. Then we have adrenergic, which is exactly for adrenaline and noradrenaline. We have dopaminergic, which is again for dopamine. Serotonergic. Please note that all the serotonergic receptors are G protein coupled receptors except 5-HT3. Except 5-HT3, all the receptors are G protein coupled receptors. Next one, we have purinergic receptors. Even your cannabinoid receptors. Cannabinoid receptors are all G protein coupled receptor type A. Moving on to the next one, G protein coupled receptor type B. This classically we have three important molecules which tend to have GPCR type B one case. And that is secretin. We have secretin, glucagon, and calcitonin. Secretin, glucagon, and calcitonin. Three major molecules which tend to have G protein coupled receptor type B. On the other hand, what about G protein coupled receptor type C? We have GABA B and metabotropic glutamate receptors. Metabotropic glutamate receptors. Glutamate receptors can be of two different subtypes, either an ionotropic or a metabotropic. Ionotropic, as the name itself implies, it is an ionode or ionic channel, whereas metabotropic receptors will be coming under G protein coupled receptors. Simple one. With this basic knowledge, we'll be explaining further, guys. We'll be talking about how G protein coupled receptor is going to be producing a particular response. Let's consider this is where the cell membrane is. We have a cellular membrane. On the surface of membrane, we have the receptor. We know that, no? Transmembrane receptor. But this transmembrane receptor is very much long. So what we do is we take hold of this end and we take hold of this end and we just comprise it in such a way that a small part is there on the extracellular area and a small part is there on the intracellular area. When I just compress it, what happens is it crosses the membrane 7 times. That's why it is also called as 7-pass transmembrane receptors. So it appears somewhat like this. We have the extracellular domain. 1, 2, 3, 4, 5, 6, 7 times it passes through the receptors. And this is the intracellular domain. We have the extracellular domain and intracellular domain. Simple, the impulse must be received from the extracellular area and passed down towards the intracellular area. On the intracellular area, this receptor is bounded with 3 different set of proteins. 3 different set of proteins it will be bonded with. The first one is called as alpha. This is called as beta, whereas this is called as gamma. This is what we call as alpha, beta, gamma trimer. This is called as alpha, beta, gamma trimer. 3 molecules are together. All these 3 are together called as G proteins. Simple. All these 3 are together called as G proteins. So the receptor is actually coupled with those proteins. That's why this receptor is also called as G protein coupled receptor. Good. But why is it called as G protein, buddy? It's called as G protein because alpha subunit is bounded with the GDP molecule, guanosine molecule, GDP molecule, and that's why this is called as a G protein. Apart from that, we also have one more molecule which is present on the membrane itself. This molecule is called as effector organ. This molecule is called as effector organ. Effector organ might be of many different subtypes. It might be an adenylyl cyclase or phospholipase C or Rho kinase or mitogen activated protein kinase. Sir, all these things are pure names. How to remember that? No need to worry. I will be explaining that one by one in few minutes. So what happens? This is what happens whenever the nerve or something is at rest. Good. Whenever the membrane is going to be at rest, the receptor is there, G proteins are there, alpha subunit is bounded with GDP molecules, and we have the effector organ there. Now comes the next important query. What if a ligand or any other molecule or a drug molecule comes and binds with the extracellular area? Now that's the next step, buddy. So again, I'm going to be drawing the membrane. We have the receptor, extracellular domain. 1, 2, 3, 4, 5, 6, 7 times it passes through the membrane. And here is where the effector organ is. Now what happens from the extracellular area whenever there is a binding of a molecule? It might be a drug molecule or it might be a physiological molecule, anything is going to be. When it is binding on the extracellular area, from the intracellular area, you remember that we have 3 important molecules. What are those? Alpha, beta, and gamma. Alpha GDP will be converted to alpha GTP. Diphosphate will be converted to triphosphate. And when this diphosphate is converted to triphosphate, alpha GTP will be dissociated from the beta gamma subunit. Alpha, beta, gamma are there. All these things are together. But alpha GTP is going to be coming out from it. Beta gamma will also be coming out from it in certain receptors. In some receptors, it will still be there, but in most of the receptors, it will come out. Again, both these things is going to be dissociated. Now, what will happen with this alpha GTP? This will go bind with the effector organ, thereby produces certain responses. So here we have alpha GTP molecules and we have beta gamma subunit. Beta gamma subunit is separate and alpha GTP molecules are separate. This alpha GTP molecule is what we call as the active form. This is what called as the active form. It in turn will bind with the effector organ, thereby it will produce amplification. That's why this is also called as amplification receptor. G protein coupled receptor is also called as amplification receptor because the responses are going to get amplified. A single ligand, if it is binding on the extracellular area, the effects are going to be amplified to very much higher end. And because of this, why is there an amplification? Because from a single effector organ, there will be release of lots of second messengers. There will be release of lots of second messengers. Now, what will happen, buddy? So here, what all we have seen, when the ligand is binding, alpha and beta gamma subunits is going to get separated. Alpha will go and bind with the effector organ. Beta gamma subunits, what will happen to those? It will also bind with certain target proteins. It will also bind with certain target proteins, guys. Remember this. Why? Because previously we used to say that only alpha tend to bind with the effector organ to produce a response. But recently we have seen that, not only recently, post 1990 or post 2000s, we have seen that even beta gamma subunit is also involved in production of certain responses. Don't worry, we'll explain about what exactly are those responses and how it is going to be produced. Now second messengers are produced, the effects is going to be seen. We'll look into the effects later on. Now, how the total number of effects is going to be stopped? The total effects is going to be stopped when the ligand is going to be unbinded. When the ligand is going to be unbinded, which means the ligand is moving out or the ligand is going to get broken down. Now, there is no impulse which is coming towards the intracellular area. What happens now is, here we have the membrane. Again, we have the G protein coupled receptor. 7 times it is passing through the membrane. And here we have the effector organ. It might be of any types. It might be adenyl cyclase or phospholipase. Anything is going to be. When the ligand is going to be unbounded, alpha molecules will again be converted to alpha GDP, which in turn will come and bind with the beta gamma subunits. So here comes the next important question. Alpha GDP is converted to alpha GTP molecules. This is done by cellular kinase enzymes, which means those enzymes which are present inside the cell or inside the cytoplasm itself. But alpha GTP triphosphate is converted to diphosphate by alpha subunit itself. Alpha has got intrinsic dephosphorylation activity. Remember that. Alpha has got intrinsic dephosphorylation activity. Alpha doesn't produce any phosphorylation. Alpha just produces dephosphorylation. So simply alpha GTP molecules will be converted to alpha GDP molecules by the alpha subunit itself. Intrinsic dephosphorylation activity. Whenever the alpha GTP is converted to diphosphate, it again comes back and binds with beta gamma subunits, which in turn will go towards the rest position. Is that clear? Well, that is what happens as per the receptor, G protein coupled receptor is actually concerned by. To explain this further, let me show some video here.
The extracellular domain, the impulse gets transmitted towards the intracellular domain. Alpha GDP will be converted to alpha GTP molecules. Alpha GDP will be converted to alpha GTP, triphosphate molecules. And once the alpha is converted to GTP, it is no longer associated with beta gamma subunit. It will be dissociated from that. When it is dissociated, it comes and binds with the effector organ. Alpha GTP will be binding with the effector organ, and this effector organ in turn will be producing certain substances. Those substances will be called as second messengers. Is that clear? And all these things is going to happen only until the extracellular domain is bounded with the particular neurotransmitter or the drug. When the drug or the neurotransmitter just goes out from that receptor, this alpha GTP will be converted to alpha GDP again, right? This is done not by an enzyme, guys. This conversion of triphosphate to diphosphate is done by the alpha subunit itself. Or when a drug has been given, this drug or a neurotransmitter will bind with the extracellular domain. When it is binding with the extracellular domain, the impulse gets transmitted towards the intracellular domain. Alpha GDP will be converted to alpha GTP molecules. Alpha GDP will be converted to alpha GTP, triphosphate molecules. And once the alpha is converted to GTP, it is no longer associated with beta gamma subunit. It will be dissociated from that. When it is dissociated, it comes and binds with the effector organ. Alpha GTP will be binding with the effector organ, and this effector organ in turn will be producing certain substances. those substances will be called as second messengers. Is that clear? And all these things is going to happen only until the extracellular domain is bounded with the particular neurotransmitter or the drug. When the drug or the neurotransmitter just goes out from that receptor, this alpha GTP will be converted to alpha GDP again, right? This is done not by an enzyme, guys. This conversion of triphosphate to diphosphate is done by the alpha subunit itself, or when a drug has.
Okay, guys, so this is which I was explaining. So this is what I was explaining till now, buddies. So how the receptor is going to get stimulated and how alpha subunit and beta gamma subunits is going to be behaving differently. Now we have to look into one important consideration, that consider here is where the membrane is. As we told, we have the effector organ here. We have the effector organ here. Alpha subunit is bounded here, GTP molecules. This GTP is broken down to GDP by the alpha subunit itself. Is that right? But we have to note on important points. This conversion will be increased, or to say increased GTPase activity. Increased GTPase activity will be seen whenever it is bounded with the effector organ. Simply put, alpha GDP is there, which is converted to triphosphate by the cellular molecules itself. This in turn will bind with the effector organ, which is releasing certain second messengers. But the conversion of GTP, triphosphate to diphosphate, is going to be exaggerated. Simply put, alpha GTP doesn't want it to be in triphosphate form. As much early as possible, it will be it will just automatically be converted to guanosine diphosphates, thereby going back and binding with beta gamma subunits. Well, this actually happens because of release of certain molecules called as regulators of G protein signaling proteins. Regulators of G protein signaling proteins, also called as RGS molecules. Regulators of G protein signaling proteins. When these proteins are getting released, that will increase the GTPase activity, quickly releasing the alpha GTP from the effector organ. That's the reason, even though the effects are getting amplified, even though the response is going to be increased, at one point of time, the response will be stopped by itself because of these RGS proteins. An important question, buddy. Even for your exams, RGS proteins is a very important concept. That's it. Now let's look into what are the types of receptors. G protein coupled receptors might be of different types. What all we have seen till now, we have explained about what exactly is a G protein coupled receptor, what exactly is a receptor first of all. Then we explained about how the GPCR tend to be producing its mechanism. Now let's talk about the types of it. We'll start with the first one, GS receptors. Let's start with the first one, GS receptors. GS receptors is going to be stimulating alpha S proteins. We all know that. GS receptors is nothing but the type of the G protein coupled receptor, which means intracellularly it is bounded with alpha S proteins. If the intracellular protein is alpha Q, that receptor will be named as GQ receptors. If the intracellular protein is alpha I, that receptor will be called as GI receptor. Simple. I hope you understand where I'm coming. Now, when this GS receptor is getting stimulated, alpha S protein will be converted to alpha S GTP, which will bind with an effector organ. Now, this alpha S protein in turn will be binding and stimulating adenylyl cyclase, AC. Adenylyl cyclase will be stimulated. Now, what will happen if adenylyl cyclase is getting stimulated? This in turn will be converting ATPs to cyclic AMP. And that's what concept of adenylate cyclase, no? Cyclical form, simple. So ATP will be converted to cyclic AMP. This cyclic AMP in turn, as I've told, will be moving inside the nucleus. Thereby protein synthesis is going to be increased further. Protein kinase A will be synthesized, which in turn will be producing certain responses. Please note that many different responses can be seen because of this protein kinase A. Primarily, I'm going to be talking about what will happen in the cardiac muscles and what will happen in the smooth muscles. In the cardiac muscle, there is going to be contraction, and smooth muscles, it is going to be relaxation. Remember this, that's a basic concept here. Any GS receptor, if it is there on a vascular smooth muscle, it will produce relaxation, which means vasodilatation. Any GS receptor, if it is there on the cardiac muscle, it will produce contraction, simply increased cardiac contractility or increased heart rate. Anything is going to be, or positive responses is going to be seen over the cardiac muscles. Now, the cyclic AMP is not going to be remaining as cyclic AMP. It needs to be broken down to AMP, 5-AMP. This breakdown will be happening with the help of phosphodiesterase molecules. Many different phosphodiesterases are involved, primarily phosphodiesterase 3 and phosphodiesterase 4. Right, this is what happens whenever GS receptor is getting stimulated. Now let's talk about what are the drugs which is going to be acting up here. We have an experimental drug called as forskolin. Which directly stimulates adenylate cyclase. Point number one. The second drug, we have some drugs which tend to be inhibiting this phosphodiesterase 3 or 4. What if I inhibit phosphodiesterase 3 or 4, buddies? Cyclic AMP will not be broken down. Cyclic AMP will accumulate in the body. More cyclic AMP means more protein kinase A, more cardiac muscle contraction, and more smooth muscle relaxation. The first drug which is going to be producing that is theophylline. I hope you all know about theophylline. Theophylline T is going to be producing bronchodilation. How it is producing bronchodilation? It is inhibiting phosphodiesterase 3 and 4, or simply non-selective phosphodiesterase inhibitor. By inhibition of that, cyclic AMP will be accumulated in the bronchial smooth muscles, which in turn will be producing bronchial smooth muscles, right? So smooth muscle relaxation. It produces bronchodilation. Happy. The second one, we have roflumilast. Roflumilast is a selective phosphodiesterase 4 inhibitor. Roflumilast is a selective phosphodiesterase 4 inhibitor which inhibits phosphodiesterase 4, thereby increases cyclic AMP. It has been approved for COPD, chronic obstructive pulmonary disease. Apart from that, we also have mildrinone. Don't call it as mildrinone, call it as mildrinone. Why? Because we have certain separate set of drugs called as findrinone, candrinone, enamrinone, not enamrinone. Findrinone and candrinone are different. You understand that? Those drugs are acting up in the kidneys. Those are aldosterone receptor blockers. To prevent the confusion, just always pronounce these drugs as mildrinone. We have an I there. Mildrinone. Again, we have enamrinone. We have vesnarinone. These drugs are all phosphodiesterase 3 inhibitors. Some drugs also will inhibit phosphodiesterase 2B also, but primarily phosphodiesterase 3 is getting inhibited. If phosphodiesterase 3 is getting inhibited, cardiac muscle, what will happen to the cardiac muscle? It increases the cardiac muscle contraction. When the cardiac muscle contraction is getting increased, this drug can be used for the treatment of congestive cardiac failure, especially acute heart failure. I can use this. What exactly is failure, buddies? Cardiac muscle is unable to pump out enough amount of blood. So if we give that drug, it will increase the cardiac muscle contraction. Simple. Now we'll move on to the next type of receptor. Let's move on to GI receptors. Why are you talking about GI right now? Very simple one, because this GI receptors, if it is getting stimulated, it will increase the levels of alpha I proteins inside the cytoplasm. Alpha I protein will bind and inhibit adenylate cyclase. When AC molecule C, GS receptor stimulates alpha S proteins. So we have two different types of proteins. If alpha S protein is getting stimulated, that will bind with adenylate cyclase, thereby stimulates it. If alpha I protein is getting stimulated, that will bind with the effector organ or adenyl cyclates and inhibit it. Simply, alpha S will increase cyclic AMP, alpha I will decrease cyclic AMP. Two major complexes. Just the responses is going to be different. That's it. We'll move to the next one, GQ receptors. GQ, again, the receptor's name is going to be GQ. This is going to be stimulating phospholipase C. I hope you remember that I was talking about 4 different types of effector organs, guys. Adenylate cyclase, phospholipase C, Rho kinase, MAPK, mitogen activated protein kinase. Out of this, the most important ones are the first two ones, adenylyl cyclase and phospholipase C. What will happen if phospholipase C is getting stimulated? This will convert PIP2, phosphatidyl ionocetal diphosphate, to IP3 and DAG. IP3 and DAG. These molecules in turn will increase intracellular calcium. Intracellular calcium levels will be increased, which in turn will be increasing protein kinase C, thereby that will be associated with smooth muscle contraction. This will be associated with smooth muscle contraction. Why is there a contraction, buddy? Because calcium is getting increased intracellularly. Now this IP3 and DAG, which are actually broken down from PIP2, this will be happening till the agonist or till the drug is binding with the GQ receptors. When the drug is moved out, you know what will happen? IP3 and DAG will join back together to resynthesize PIP2, because PIP2 is actually a membrane molecule. So these two, IP3 and DAG, will join together to form PIP2 again. This resynthesis of PIP2 is actually inhibited by lithium. You know what lithium, buddy? Lithium is an anti-maniac drug. This anti-maniac drug mechanism is it is going to be inhibiting in this particular step. We'll be discussing further in the lithium mechanism of action in the anti-maniac drugs again. Now, so please note that IP3 and DAG is going to be increasing the calcium levels. That is the reason why there is smooth muscle contraction. This is not going to be seen with GS receptors because calcium levels is not going to be increased by that. Calcium levels will be increased only by GQ receptors. So simply put, here GQ is called as a receptor. Of course, from GQ, there will be release of alpha Q proteins. Alpha Q proteins. Alpha Q is nothing but the G protein. Phospholipase C is the effector organ. IP3 and DAG are called as second messengers, whereas calcium is actually called as third messenger. Calcium is actually called as the third messenger. So please look into the same sequence. What is the receptor? What is the G protein? What is the effector organ? What is the second messenger? What is the third messenger? And what actually is the response which is produced? Is that clear? Now, let's move to the next important subtype, that is G0 receptors. G0 receptors, simple guys, we have the membrane. On the surface, we have the G protein coupled receptor. Intracellularly, we have alpha 0 protein. Good. Alpha 0 protein is bonded with beta gamma subunits. When this G0 receptor is getting stimulated, alpha and beta gamma is going to be dissociated. Beta gamma here will be binding with an ionic channel. So here is where I was talking about. You remember that beta gamma subunits also can produce certain responses, and this is where the response is seen. Here, beta gamma subunit will go and stimulate an ionic channel. This is very much less common, body, which is seen inside the human body. Most commonly, it is going to be GS, GQ, or GI receptors. The last one is G12 bar 13, G12 bar G13, which tend to stimulate Rho kinase. Now comes the most important query. What exactly is the function of Rho kinase? Rho kinase will be producing smooth muscle contraction, number one. Number two, it is involved in cell proliferation and it is involved in angiogenesis, which means if a patient is suffering from any tumors, if Rho kinase is getting stimulated, we know that these are intracellular signaling pathways. When Rho kinase is getting stimulated, there is more chance of tumor proliferation to be seen. That's why we are currently developing lots of drugs which is targeting the Rho kinase. We have netarsudil, we have fasudil. Drugs which are inhibiting this Rho kinase, we have netarsudil. We have fasudil. Netarsudil is used against glaucoma, drug which is used for glaucoma, and fasudil is approved against angina. Fasudil is approved against angina. We'll explain that again. Here we are just talking only about the G protein coupled receptors. So till now, what all we have seen, guys? We have seen about what exactly is the receptor and what are the types of G protein coupled receptors, how G protein coupled receptors is working up inside your body, what are the effector organs, all the other concepts. Then we looked into the types of G protein coupled receptors. We have completed it. Coming towards the last important one, this is called as desensitization. This is explained as desensitization. What exactly is this? This is a very important concept, buddy. Even for your exams, we have seen lots of universities asking about GPCR desensitization as a short note. So I will explain this concept with a simple diagram. I will make it as simple as possible. Don't worry. Consider this is where the membrane is. Again, consider I'm going to be drawing a membrane. And on the surface, we have 1, 2, 3, 4, 5, 6, 7 G protein coupled receptor. Intracellularly, we have alpha, beta, and gamma subunits. Whenever there is continuous stimulation of an agonist molecule might be a ligand or it might be a drug molecule. Whenever there is continuous stimulation of the receptor, intracellularly, alpha, beta, gamma subunits will be dissociated and binding with the effector organ and producing certain responses. But when this is happening on a long-lasting basis, what happens is these will stimulate a molecule called as G protein receptor kinase molecules, GRK molecules. This will stimulate a molecule called as G protein receptor kinase molecules. This will bind with the beta subunit. This will bind with the beta subunits. Now, what's the next step? The next step is, again, we have the G protein coupled receptor. The agonist is bounded on the extracellular area. This G protein receptor kinase molecules will stimulate or will attract one more protein called as arrestin molecules. It will attract one more molecule called as arrestin molecules. This arrestin molecule, if it is bounded with the G protein coupled receptors, it means, consider here is where the membrane is. On the membrane, we have the receptors. This is your G protein coupled receptor. And whenever this GRK is coming and binding with here, this will attract one more molecule called as arrestin. When that arrestin comes, what happens? These receptors will be taken up inside the cell. This step is what we call as desensitization. So how this is going to be happening, guys? From the membrane itself, it is going to be endocytosed. It is going to be endocytosed. We have the receptor here. Again, we have the arrestin molecule, which is bounded. From the membrane, it is going to be endocytosed with the help of clathrin-coated pits. This is called as clathrin-coated pit. With the help of this clathrin-coated pits, the whole receptors is going to be internalized inside the cells, simply endocytosed inside the cells. Now, this whole molecule is going to be taken up inside it. Inside it, I have drawn only one receptor, but lots of receptors will be taken inside the cells. We have 1, 2, 3, 4, 5, 6. For example, I have drawn 6 receptors here. Consider 6 G protein coupled receptors is getting internalized. Now, this G protein coupled receptors, which is taken up inside, will be bounded with arrestin molecules. We all know that. Will be bounded with arrestin molecules. But this arrestin molecules, once it is getting internalized, will be broken down by phosphatase enzymes. Phosphatase enzymes will break down the arrestin molecules from the surface. So now what will happen? We have the endocytosed cellular membrane with G protein coupled receptors only. Arrestin molecules will not be there because phosphatase is dephosphorylating that, leading on to removal of arrestin molecules from the surface. Now we have only the G protein coupled receptors. These proteins can either be recycled and put it up back inside the membrane. These proteins can either be recycled and put it up back inside the membrane, or these can be put up to lysosomes. Thereby, it will be marked for degradation. Now, if you could look at it, what exactly has happened here, buddy? Previously, we had around 10 or 20 G protein coupled receptors. Now, because of recurrent stimulation of certain molecules, around 5 or 6, I think I have drawn. All the 6 receptors are getting internalized with the help of GRK molecules, G protein receptor kinase enzymes, which in turn is going to be activating or phosphorylating arrestin molecules. This arrestin in turn will be internalizing all the receptors. Phosphatase will take out the arrestin, and these receptors can either be recycled to be reused after some time, after the agonist has been thrown out, or these receptors can be broken down for degradation. So previously we had around 12 receptors. Now we have only 6 receptors. The remaining 6 receptors are getting broken down. This is the concept of desensitization, or also called as internalization. Also called as internalization. And why is it called as internalization? Simple, receptors are getting internalized inside the cells, guys. So this is how the response of a G protein coupled receptor is going to be decreased. Understood the concepts? So simply, what all we have seen, guys, I told that the session will be there for half an hour. I hope I have done only for half an hour, not more than that. So what all we have seen till now, receptors, what is the use of a receptor? To pass the impulses inside the nucleus, point number 1. Number 2, G protein coupled receptors, what are the subtypes? 3 types, A, B, and C. The third one, how receptors is going to be producing a response? Receptors, G proteins, it will bind with effector organ, which in turn will be producing second messengers. What are the types of it? GS, GQ, and GI. What are the other subtypes? G0, G12, bar 13. And the last point is regarding receptor desensitization. Whenever the exam comes, if you add up these points, if you add up the same notes as per what we have given here, you will be fetching the maximum ones. And this is more than enough to understand pharmacology, buddy. Thank you so much. And we'll meet up for one more live session or one more YouTube session. Bye-bye.